I'm Tennyson Lee. I'm the consultant medical psychotherapist, so consultant psychiatry and medical psychotherapy at the Deanscross Personality Disorder Service. And attached to Deanscross, we have a research unit called the Centre for Understanding of Personality Disorder, which Cam Bowie and I co-direct. And part of the interest that we have is ensuring we do excellent research, but very much driven by our clinical work.
Cam, do you want to kind of introduce yourself?
Sure. So I'm Professor Cam Bowie. I'm a professor of psychiatry at University of Oxford, and I've been with East London Foundation Trust as an honorary consultant psychiatrist all since about 2000, originally working in assertive outreach teams and later in medical psychotherapy. And I left about the middle of last year, effectively. I've still got an honorary contract with East London, and I'm still working as the co-director of the Centre for Understanding of Personality Disorder. And hope we can continue to do the research. As Tennyson said, it's very much applied, clinically relevant, and offers remarkable training opportunities for people in understanding personality that I don't think any other trust or service does.
Great. And Emma?
So my name is Emma Larson-Thomas. I'm a clinical psychologist at Deanscross. I'm very much in the beginning of my career. So I joined the team 2 years ago, where I work both kind of clinically the majority of my time, but also 2 days a week, part of CUSP, the Centre for Understanding Personality Disorder, where I did research as well.
Great, thank you. So what kind of research are you currently involved in? If you can just kind of give us a bit of a brief overview.
Well, the work that Cam and I initially were doing was very much around issues around ethnicity and what the representation was of the different, particularly BME groups was, both in terms of in the community, so the referrals to our service. We've also looked at the actual figures within inpatient, within the trust, and also done some systematic reviews of what studies have found. And in all of them, we found an underrepresentation of minority ethnic groups in patients who have been diagnosed with personality disorder, which is both worrying but really worthy of further research, really. The other aspect that we've done a lot of work on is on and with trainees. So again, a very important aspect of personality disorder is just the attitudes that clinicians have towards the disorder. And so we did a repeat of a landmark study which was about the attitudes of psychiatrists to personality disorder. And, unfortunately found that even amongst trainees, there's an ongoing difficult attitude towards patients with personality disorder. But, again, part of what Cam and I are very keen on is to actually do some implementation. So we've done 2 studies, one which has been a training on trainees in personality disorder, and we have found with a very short intervention that there's been an improvement in attitudes towards personality disorder, which we found remarkable given the shortness of the training. And most recently, we've done a study which has, trainee psychiatrists have to take on a case for a year, have to treat a patient in psychotherapy. And we've used a particular model called transverse focus psychotherapy to help them to do the training. And again, we found very positive results in terms of how the trainees have got on with what's a very difficult task, learning how to work with a patient for 1 year in a psychotherapy setting. So again, I think that what's important about CUSP is that we're not just identifying the problem, but we're really trying to implement some interventions around that. Emma's involved in a number of other, studies, and I'll leave Emma to discuss some of our other more recent work as well.
Great.
Yeah, so Oh,
Yeah, go ahead.
Yeah. So during my time at CUSP, I've been both involved in looking at improving the service, so kind of looking at the value of having a good and robust administrator working for us, and what that means for us as well-beings as clinicians. But I've also taken part in the evaluation of kind of staff training and done focus groups around that. As Tennyson mentioned before, I've been looking at kind of improving access for BAME patient groups. And we right now also looking at patient views around they complete the kind of treatment goals when they come into our service and sign a contract for us, and how their views are around this.
Great, thank you. So what does kind of a typical day look like for you, and how do you balance research with kind of clinical work?
That's a really good question. And again, I think it does. I think one of the important ingredients is having CAM as academic sort of role in a way. So a lot of the work does happen, not in normal office hours. So CAM and I will often be in, consultation, discussion out of hours or on the weekend. And I think that's a very important part of CUSP, that we do have an academic overview over the work that we do. But a normal day would be, coming into the office, ensuring that clearly as clinicians in the NHS, the clinical work is of the utmost importance. But Em and I suppose it's very important for us as NHS clinicians as well to have well-planned times. So Em and I will have times that we try to carve out to do our research. And again, Emma will speak to the pressures of needing to attend to clinical work and ensure that we're pushing out our research. And then a lot of time is actually spent liaising with colleagues, both nationally, internationally. And, I suppose it's very easy with working remotely that one can do this. So it's really ensuring that the clinical work is of a very high standard and consistent, and then using some, trying to boundary off some time to do research as well.
Yeah.
The other thing is, to emphasize that CUSP very much emphasizes encouraging trainees to do research. So we feel that we set a platform for trainees, because the problem with the trainees have is that they have very little time within any rotation that they move through. So we've set up procedures that trainees can get involved in research. So some of our time as well, and Emma does a lot of this as well, is making set times to meet with trainees just to ensure that they're getting their research moving through the different stages.
Yeah, that's great.
I guess for me, I'm lucky that I'm having set days and protected time to do research, where during office hours, as that's kind of part of my role. But as Tennyson said, we often see that the clinical need needs to go, it's a priority for us, and that's what we need to focus on. But I can also see that the clinical work is really helping, and we often have discussions afterwards when we have a clinical meeting and thinking, okay, but this is something we want to improve on, and really starts up some feelings and thoughts around how we can improve the research and think around that.
Yeah, lovely. And I suppose last question is, why did you get involved in research? So it'd just be nice to kind of just hear a little bit of something from all of you as to why you got involved and why you like working in research.
I think it's really the interest in ensuring that our patients get a good service. And the way to ensure that, I suppose, is to be thoughtful about the work that we are doing. And I think that, Cam, Em and I are very interested both in the individual, so that the individual in front of us. But I think we all also have a thinking in terms of systems as well. So we're very interested in how the service works and how we really deliver the best at a population level. So I think it's both the clinical interest that all of us have, our interest in systems, and our interest in serving, a broader population.
think it makes me a better clinician as well. I always looking for kind of ways to improve and stay up to date with research and thinking about new areas in the field as well. So for me, I really want to. I think that balance between research and clinical work has been really important for me, and I do think it makes me, as I said, a better clinician being part of research.
Right.
I've just got a few thoughts. So I think globally we know that the best clinical outcomes are where research and services are integrated, and what research does is create curiosity and interrogate our practices and the way we think. And what it also does for this particular type of patient population is it creates space to think and insists that we have some sort of coherence in the way we approach patients who've had multiple traumas all their life. And the last thing they need is a fragmented, traumatizing service that doesn't think, because they are unable to think. So it's very important that research actually creates space and also raises issues that are overlooked and that people are silent about because they're so busy in crisis. So often you'll find that clinicians working in acute services don't understand the need for coherent space and thinking, and to slow down sometimes to question what they're doing. And we know this is the sort of environment in which people, for example, minorities might not have personality aspects recognised. We know they're underdiagnosed in minorities, whilst psychosis is overdiagnosed. And now there's a real question there about what's going on and how are we missing some of the more subtle nuances. And then generally the personality aspects aren't recognised in general adult psychiatry care as a comorbidity, or it's difficult for people to recognise them. People often only see the prominence or symptoms and assume this is the illness rather than underlying personality issues that need resolving. This also happens in medical care as well. And finally, the whole issue is of how do you provide this coherent service system in which people can benefit, and not many other people are thinking about it other than those working in medical psychotherapy and psychotherapy services more generally, not because they particularly want lots of time and you know, it's not an easy path is what I'm saying. It's quite an entangled process where people have to give a lot of themselves in a way that is not so straightforward and is different from acute care where you follow an algorithm. Perhaps a lot of the time psychotherapy services, people having to question and rethink and think, how do you provide the best care for this particular individual in this particular context? And for research strengthens that, because at the same time it's easy not to be aware of the guidance and evidence that's around, so we have to synthesize it on a regular basis. And I think the centre's done all of those things over a long period of time in a very patient, gentle way, and is probably understated in its achievements and representation more widely in the trust and nationally.